Hello, everybody, and welcome to our TIF Talk Tuesday. I am Andrea Millers with Endogastric Solutions, and I'm very excited to have you all here with us. We have a fantastic guest physician with us. But before I give introductions about him, I do want to let you know that Karen Girth is also on tonight, and she is also with Endogastric Solutions. And if you are watching live, please feel free to ask any questions. Just type it into the chat section, and we will do our best to answer any of your questions. Also, if you are watching live, please just type in where you're watching from so we can see where you all are watching from. So our special guest today is Dr. Davinderbir Pannu. He is a board-certified physician in internal medicine and gastroenterology. He attended medical school at I'm going to say this wrong, Maulana Azad Medical College in New Delhi, India. He completed his internal medicine residency and gastroenterology fellowship at the University of Florida, VAMC in Gainesville, Florida. Dr. Pannu completed his advanced endoscopy fellowship at Northwestern University Memorial Hospital in Chicago, Illinois. Dr. Pannu practices at McLeod Regional Medical Center in Florence, South Carolina, and is a part of the McLeod Digestive Health Center. Dr. Pannu, thank you so much for joining us today. It's such a pleasure to have you.
Thank you for the introduction, and good evening, everybody.
Yeah, perfect. So we're going to go ahead and start off, Dr. Pannu. And the first thing we usually always talk about is what is GERD? So if you could please explain to everyone watching GERD, kind of what symptoms could potentially patients feel if they were suffering from GERD.
GERD, also known as gastroesophageal reflux disease or acid reflux, is a condition of the esophagus or the food pipe where there is excessive regurgitation and reflux of acidic contents from the stomach into the esophagus. And some of the typical symptoms of acid reflux are heartburn, sometimes feeling of bloating in the upper chest, and some of the atypical symptoms can be chronic cough, hoarseness, feeling of what we call as globus sensation, or feeling of something stuck in the esophagus, asthma. So it's a variation of symptoms from your typical heartburn to chronic cough. Anything can be the presenting symptom.
Fantastic, thank you. And one of the things that we always get asked, or we always hear about from patients, is when is it time to seek help? Because most people at some point in their life suffer from some sort of acid reflux, right? What do you suggest or recommend for these patients that are kind of suffering from chronic acid reflux or GERD?
So typically, if we see a patient with acute onset of symptoms, we want them to try acid reflux medications for a brief duration. It can vary anywhere between 2 weeks up to 3 months. And then we try to take them off the medications and see if that is enough. Sometimes patients will have lingering symptoms that can need longer duration of medication. And we also are looking for any high-risk symptoms or history, which includes difficulty swallowing, unintentional weight loss, absolutely no response to acid reflux medications. We also want to, based on the patient's age and other risk factors, sometimes need to look into their cardiac history as well. And these risk factors can help us identify who needs endoscopic evaluation, which is the first step in going forward with further evaluation.
Perfect, thank you. Before we talk about all of the evaluations or the diagnostic testing for GERD, talk a little bit about what unmanaged GERD could lead to for some patients potentially.
When I talk to a patient about unmanaged GERD, I try to put them in a box that helps to understand what we are trying to achieve and what we are trying to prevent. So GERD can start with simple symptoms of acid reflux. Then if endoscopy is done and the esophagus looks completely normal, we may call it non-erosive reflux disease, meaning there's no damage to the esophagus. The next, box is reflux with damage to the esophagus, what we often call as esophagitis. The next box is the Barrett's esophagus, which are some changes in the cells and the lining of the esophagus from chronic exposure to acid. And Barrett's esophagus, again, can be in different categories and can lead up to esophageal cancer. Not all esophageal cancers arise in Barrett's esophagus. That is also important to know. But if we can prevent this progression in even a single patient, that is always our goal.
Fantastic. Thank you, Dr. Pannu. I love that box analogy because it really helps you understand the progression of the disease, if you will, and kind of where patients are. And with that said, I did see a couple of questions that came in early on before we even started that one of them had to do with Barrett's esophagus. So I'm going to pass it over to Karen to get to those questions really quick.
Wonderful. Thank you so much. We do have a question, Dr. Pannu, and they're asking, they were just diagnosed with Barrett's esophagus. Is TIF an option for them?
It depends on, again, putting you in a box with Barrett's esophagus, were there major changes in the cells? Even Barrett's esophagus can have some high-risk changes, some low-risk changes. Whether it was a short segment of Barrett's esophagus, those things will help us determining whether TIF can be performed. And yes, TIF can be performed in these patients. But one important thing to understand is that this particular patient may need to continue PPI use as well as continue surveillance endoscopies, with or without TIF.
Perfect. Thank you. Yeah, Karen, before we go on to his next questions, I'm going to actually have Dr. Pannu explain the different diagnostic tests that you would generally have patients go through if you were trying to diagnose them with GERD.
When we are evaluating GERD, especially if we are thinking of doing an invasive procedure, first question we like to answer is, what is the most important symptom to the patient we're trying to fix? And next question that comes is there an anatomical problem in the esophagus or the stomach that is contributing to that symptom? That leads us to do a endoscopy procedure where we put a camera through the mouth and look at the esophagus, the stomach, the junction of the esophagus and stomach, and also if there is any presence of any hernia, which can help us determine what is driving the patient's symptoms. Sometimes, if we see visible evidence of, for example, inflammation, or as you said, Barrett's esophagus, that points us in the direction of GERD more than other diagnoses. If your endoscopy exam is completely normal and we still have symptoms, then we would likely do some other testing where we measure the pH or measure the amount of acid coming up into the esophagus before we go in the direction of anything invasive. And next, sometimes we do a barium swallow, which is a study where we do X-rays and we ask you to swallow a contrast liquid. And lastly, sometimes we have to look at the muscles of the food pipe to make sure there is nothing else that is contributing to these symptoms. And again, for me, the biggest uh, closing the loop kind of a strategy is that what are we trying to fix? Is that truly the problem? And is there an anatomical issue? So those are the three questions.
Fantastic. Thank you. Can you talk about what options today are available to treat GERD? Past, you talked a little bit already about, medical therapy, maybe lifestyle changes or dietary changes. And then from there, what are the kind of surgical options, if you will, that are available today?
So in terms of surgical options, there are a handful of options available to the patient. The first thing to talk about is laparoscopic surgery with hiatal hernia reduction and fundoplication procedure. This has been around for 30 plus years. Other, next option is surgical hernia repair and a procedure called LINX device placement. And then we go to endoscopic fundoplication or TIF that we're talking about today. And then there are certain, in terms of endoscopy, other devices available to name some strata, radio frequency ablation, and so forth. What I see this is progress and evolution of technology, where you could do something with the open surgery, then came laparoscopic surgery, then came minimally invasive surgery, and then certain things you can do with endoscopy. Of course, with limitations, but that's just a gradual evolution of technology.
Fantastic, thank you. And it's probably the perfect time now to talk about the TIF procedure. Maybe explain to the viewers what is the TIF procedure and how does it work?
Again, very important to emphasize again, we are trying to, address the patient's most important symptom. If it is a typical symptom of acid reflux and all the pre-procedure evaluation has been done, then we schedule the patient for the endoscopic fundoplication. It generally involves initially office visit before the procedure, where we review patients' previous endoscopy reports, if available. We review the pathology results. We review that the patient has gone through appropriate lifestyle modifications, medications that they have been on. And then with discussion with the patient, we make the decision to go forward with the TIF procedure. In the office, we also discuss the diet modification that is needed after the procedure, as well as how much time the patient will need off from work, travel, and so forth. So once the procedure is scheduled, we schedule it on a, about 4 to 6 weeks out. We block appropriate amount of time. The procedure is done with general anesthesia, which means that you are put to sleep by anesthesiologist with a complete sedation. And then we go with a camera through the mouth into the esophagus. We reevaluate our decision of performing the TIF under anesthesia and make sure that is the right thing that will help you. And then once that determination is again made, we use a tube which is the device also known as the esophagus or the transoral incisionless fundoplication device that we load onto the scope and go down the mouth. And we fire a certain amount of fasteners that help us plicate the bottom of the esophagus and also help in reducing a certain amount of esophageal hernia. And the procedure takes about anywhere between 30 to 45 minutes. Post-procedure, we observe you in the recovery room approximately 4 to 6 hours. We have you on certain medications during that time. And then in consultation with the patient, if it is determined that it is safe to go home, you go home that same day. If it is determined that for any reason pain is not controlled or there is any other problem, then we observe overnight. And that's the general process. And then we see you back in follow-up another 4 to 6 weeks.
Fantastic. Thank you so much for that. Karen, I see a lot of questions popping up on Facebook, so I'm going to go ahead and pass it to Karen to get some of those questions answered.
Wonderful. Thank you. I'm going to go ahead and hit on this question. There's been a couple regarding the post-procedure diet, since you did hit on that a little bit. How long, they're asking, post-procedure can you resume a regular diet? Or what does the post-procedure TIF diet look like?
So usually about when you're saying regular diet, completely regular diet at about 3 to 4 weeks. We keep you on a liquid diet that we slowly progress to soft foods, and then we go on to a regular diet. A lot of times I see patients in 2 to 3 weeks afterwards, and if they're doing really, really well and they have no problem with the liquid diet they have been on, I will ask them to push the diet a little bit. And it is very subjective. It depends on the patient, but about 3 weeks, you can say.
Okay, well, perfect, because I do have a question or maybe more of a comment here. If I get the TIF, can I get back to eating Nashville hot chicken?
Probably, hopefully, in 3 to 4 weeks after the procedure.
Wonderful. And then we have a question. How long post-procedure can you start walking or running again? Or what does the exercise routine look like once you've had the TIF?
So light exercise, like walking, slow running, you can resume in the couple of days after the procedure. But strenuous exercise, I do remember I did have a patient who would work at a gym, and we advised them to take rest for 2 to 3 weeks. And again, light exercise is okay within the first few days.
Wonderful. And I am going to, if you don't mind, back it up just a bit, because we do have a couple questions around PPIs. I've got a question here. I'm on PPIs now, prescribed by my primary care doctor. How long do you recommend a person stays on PPIs before evaluating a surgical intervention?
So a lot of this comes down to patient preference. PPIs are, medications around for last 50 years. Over the last 10 years or so, there has been a lot of literature published on long-term side effects of a PPI. So in terms of that question, the first question to ask is, are your symptoms controlled on acid reflux medications? The second question is, have you had any of the long-term side effects from the medication used? Third question that comes into play is, what is the age of the patient? that, and what is their goal going forward. So all those factors go into play. But if there's a certain group of patients who have been on PPI, who are above a certain age, history of smoking, some of that group of patients is also at high risk of Barrett's esophagus, and we do endoscopy even if they're not symptomatic. So also sometimes some patients will come to us after reading the list, what is available on PPIs, the side effects, and they ask us that we want to be off the PPI. So that is also a question that is frequently posed to us. So it all depends on the benefit, the risk of the medication, and other factors that go into play. I wish it was a simple answer to tell you that, in 5 years you need to take a look, but it is not.
Thank you for that. And just the last question I have before I give it back to Andrea is, there's a question as why does medication seem to lose its effectiveness over time?
So that's a good question. There are commonly used two classes of medication. One of the type of medication is known to have a effect of, in the medical term, we call it tachyphylaxis, where your body gets used to the effect of the medicine. The receptors don't respond as well. In other cases, there are other factors that can cause the effect of medication to decrease. It could be lifestyle factors, including change in diet. It could be weight gain. It could be the dose, the timing of the medication. What is recommended by our society guidelines is that you can switch between two different PPI medications if the patient is not well controlled, but a third switch doesn't necessarily add any benefit. Also, there have been studies on each type of medication, omeprazole, Nexium, Dexilant, how much of a pH lowering effect they have. And there is some thought that you can switch from one type of medication to another, which lowers the acid in the stomach more than the other. So the many factors can contribute, but it is a very common situation where it has helped for a long time and then the effect wears off.
Thank you. Thank you for that. Andrea, we'll bring it back to you for some more questions.
Fantastic. Thank you. Dr. Pannu, can you talk about how your patients are tolerating the TIF procedure and how are they feeling after the TIF procedure? You've been doing a couple of procedures now, and I suspect that you're seeing them, post-procedure. What are they saying about the TIF procedure and how they're feeling afterwards?
At our hospital in Florence, we are approximately 2 years out of the first TIF that was performed. So we have some follow-up on short-term and not too long of a follow-up, a couple of years follow-up. So acutely, just after the procedure, again, some people will have more esophageal pain than others. Generally, around 6 to 8 weeks, that pain is better. At about 3 months, we ask the patient to try to come off the medication to see if that will help. And what I've seen is that close to, I would say, 85 to 90% of the cases that I have personally done have done very well. And starting off, I was definitely skeptical about this procedure as well, because it took me about 6 months to even get the first patient done, between getting the device and getting it done. But now that I've seen a good number of outcomes, I feel very confident that it has helped a lot of patients who were having a lot of problems. So it's definitely
fantastic. Maybe let me ask you this: what made you decide to start offering the TIF procedure?
It seemed that a lot of patients that we see in the gastroenterology office, acid reflux is a very, very common problem. Almost, I would say, 30 to 40% of the patients will have some acid reflux. And talking about lifestyle modifications and medication use, there seemed to be no next step. If I offered the patient to refer them to a surgeon, there was always concern how major a surgery it could be. So this has helped me have a bridge between that conversation, between uncontrolled symptoms, referring to surgery, and doing something with endoscopy. So it has definitely filled that gap.
Fantastic. Thank you. Before we conclude for the evening, I want to just pass it over to Karen real quick. Do we have any other questions that haven't been asked, or anything that we need to ask Dr. Pannu before we conclude?
We do. I have a couple questions. I've got a question. Does the TIF procedure address chronic laryngitis caused by silent reflux?
That's a very common clinical question to me as well. When I'm trying to address this question, I go to great detail to evaluate that these symptoms are truly related to acid reflux. So this kind of a clinical patient will need a lot more testing to ascertain that the reflux is contributing to laryngitis. Again, it involves pH testing, endoscopy. And then the next discussion I have with them is the typical symptoms of acid reflux. The success is going to be 80 to 90%. Atypical symptoms, if the main goal is to fix the laryngitis, your success at this with the fundoplication is going to be 50 to 60%, because it is not a typical symptom of acid reflux.
Thank you for that. And we have one more question that just came in. I have a really large hiatal hernia plus GERD. Would you recommend the TIF procedure, or do you think I'm a candidate for a TIF procedure?
As we discussed, TIF is a sort of a evolution in technology from surgery to laparoscopic surgery to endoscopic fundoplication. So there are certain limitations to this procedure at this time. And with regards to this question, the hiatal hernia needs to be less than 2 centimeters in order for us to have good, outcome in terms of acid reflux with this procedure. In this particular situation, we will work with a surgeon where the surgeon can help repair the diaphragm and the hernia, and the fundoplication is performed with endoscopy at the same time to help with the reflux, this is different than a traditional surgery with fundoplication, as there are certain long-term effects of a regular fundoplication that are not associated with this technique.
Wonderful. Thank you. Andrea, back to you.
Fantastic. Thank you. All right. Well, Dr. Pannu, I'm going to give you the opportunity to give any parting thoughts for our viewers tonight. Any recommendations for those that are suffering from GERD?
I think main thought is again, yes, these procedures are available, but we should not forget the basics of acid reflux. Go through thorough lifestyle changes. If weight loss is needed, must give a good attempt at that. Then medication, appropriate dose and timing. Then you go to switching medication if needed. And then you think about invasive intervention to make sure your symptoms are controlled. Not something that that should not be the first thought in terms of managing this, and must have thorough evaluation as to what symptom we are trying to fix and if we are going to have good results with this technique.
Fantastic. Thank you. And if you're in the Florence, South Carolina area, you can see Dr. Pannu out there. If you're not, you can go to gerdhelp.com. We do have a list of physicians on there where you can type in your state or zip code and you'll be able to find a physician near you. In addition to that, we do have a mobile app. So if you go to your app store, you can search for GERD Help and you'll be able to download that app. And the app has lots of information that can help you, has articles, explanations of everything we discussed today. Also allows you to track your diet, track your symptoms. So if you ever have a conversation with your physician, you'll be able to kind of tell them what's been going on. So Dr. Pannu, I can't thank you enough for joining us. I know everyone at Endogastric Solutions appreciates your expertise and partnering with us, and as well as those potential patients that might be watching, that might be suffering from GERD, appreciate it as well. Thank you. You're welcome. Thank you, everybody, for joining us. You can catch us every Tuesday for our TIF Talks. Until then, we'll catch you next time. Stay safe out there.